Hello, everyone. Welcome back from the break. Now we are going to go into the last session of today for this stream, and it's going to be on lymphomas. I will now hand over to our facilitators.
Good morning, good afternoon, good evening, everyone. My name is Dr. Sitna Mwanzi. I'm an oncologist from Kenya. And I'd like to welcome you to our final session on lymphoma. This session was meant to be last Sunday, but we had technical issues, and that's why it's happening today. So I'm very grateful to our speakers who are already online, Dr. Raina, Dr. Stephen, and Dr. Anna, for giving us a second chance to give us their presentations. So first off, I'd like to invite Dr. Raina to give his talk on pediatric lymphoma, a unifying model for Burkitt's lymphoma development, integrating epidemiology, molecular abnormalities, and cellular proliferation. Welcome, Dr. Raina.
Yeah, thank you very much for the introduction. It's a pleasure for me to give you my view on a model how Burkitt lymphoma, both sporadic variants and endemic variants, might occur. And thank you very much for the invitation. It would have been a pleasure to meet all in person, but I hope it's great that we at least have the opportunity to discuss online. If you look into the current WHO classification for Burkitt's lymphomas, essentially there are three variants which are distinguished based on mainly epidemiologic basis. On the one hand, it's the endemic variant, predominant in the malaria belt and closely associated with Epstein-Barr virus infection. We have a sporadic variant in Western countries in which roughly around 10% probably are EBV positive. And we have immunodeficiency related Burkitt lymphomas in patients with inborn or acquired immunodeficiencies. There's another group which is Burkitt lymphoma without a MYC translocation, but this will be likely renamed in the new WHO classification, not anymore as Burkitt lymphoma, but as a large B-cell lymphoma. If you follow this kind of historic classification, there's an alternative possibility to group these cases, and that's something I will discuss during my talk. It's on the one hand, the cases which are EBV positive, and on the other hand, which are EBV negative. Obviously, they are in a certain way, this classification is in a certain way confounded by the area where the Burkitt lymphoma is diagnosed. But it will be an intriguing question in how far EBV positive sporadics resemble EBV positive endemics and EBV negative endemics might resemble sporadic Burkitt lymphomas. So I was asked to provide or discuss a model of Burkitt lymphoma genesis. And that's a bit of basis of my model. I would like to propose you first, and then I would give you some outlines what's the basis for this model. To my view, there is a germline predisposition in Burkitt lymphoma. You can see it in the immunodeficiency cases, and there is predominantly a point to DNA repair and immune responses. And the other important part is probably an antigen, which affects particularly mucosal sites and the mucosal immune response. And given the early age of diagnosis, in many cases, I think it's a primary mucosal immune response we discuss. These together lead to the occurrence of the IgMYC translocation, which is the hallmark of Burkitt lymphomas. But overexpression of MYC essentially leads cells to apoptosis. So it's not that the cell outgrow, but many cells will die. So we need additional chromosomal operations or genetic operations which allow the cells to survive. And we can discuss whether these can occur in part also before the IgMYC translocation. So if all these few operations come together, then the cells have a growth advantage and they rapidly grow in an exponential phase, and we might have a few late genetic alterations. In cases of EBV positive Burkitt lymphomas, part of these genetic and external factors can be driven by EBV or by malaria. So malaria predisposition is associated with predisposition We know that Plasmodium is driving AID and gives rise to the translocation, but we also know that EBV can change gene expression. So what's the evidence for germline predisposition? So there are inborn errors in immune regulation associated with increased risk of Burkitt lymphomas. There's inborn DNA repair deficiencies with an increased risk of Burkitt lymphoma, some developmental disorders. Genetic evidence might also come from the higher male to female rate, at least in some types of Burkitt lymphoma and by association with malaria. And at the end of the day, there are familial clusters which have been associated with some genes, which also show somatic aberrations in Burkitt lymphoma. The hallmark genetic aberrations, as you all know, is the Burkitt translocation, juxtaposing the MYC gene next to one of the immunoglobulin loci. And we have looked in the German consortium in sporadic Burkitt lymphomas in this in very much detail. That's a busy slide, but the main message is the vast majority of the breaks in the immunoglobulin locus are associated with class switch recombination. And the particularly target is the Ig alpha region. So the region necessary to express the constant region alpha. And this is immunity, particularly at mucosal interfaces. So we think there is a population at risk at early ages of development in which intestinal B cells on first exposure to microbia want to switch to IgA. And if there is something going wrong, they might give rise to the Burkitt translocation. This might not be true in all kinds of Burkitt lymphoma, because we know that in endemic Burkitt lymphomas, we mainly have translocations affecting the joining region. So these might occur during somatic hypermutation in the later stage of B cell development. Another point which could point to microbial infection is if you look into breast Burkitt lymphomas, this is frequently associated with lactation. And we know from old studies back to the 1975 that if you give bacteria to pregnant women or lactating women, these develop B cell clones expressing IgA and traveling to the breast. So it's a kind of, again, primary immunity for the fetus, which is given by the mothers. And that's probably additional evidence that the mucosal immunity in this example conferred by the mother to the fetus plays an important role in Burkitt lymphomagenesis. So I think the type of translocations and the presentation, either in the ileocecal region or in the jaws, could point to an antigen which particularly exerts its function on the mucosal cells, so mucosal B cells, and that the antigen might particularly the first experience to antigen, which is important for this for the development of Burkitt lymphoma. And if you take immunodeficient patients, they might have lost their memory in IgA and might again have a new primary mucosal immune response, which would also fit into this scheme. Now, what about the late alterations? If we perform genomic sequencing, there is a set of highly recurrently mutated genes, MYC itself, ID3, cyclin D3, and so on. And this is data from sporadic Burkitt lymphomas. And if you group this together, you essentially have a module, which is genes which affect proliferation and survival. There are genes which affect the SPY-SNF complex, and there are genes affecting the BCR tonic signaling, which are affected in Burkitt lymphomas. Probably the most prominent is ID3, which is induced by MYC itself and binds TCF3. Mutations in ID3 lead to release of TCF3 and activation of survival pathways. Others are cyclin D3. So there is only a few modules which need to be deregulated in Burkitt lymphomas in addition to the MYC translocation. In our data in sporadic Burkitt lymphomas, we have 60 to 70% of patients or tumors showing ID3 or TCF3 mutations. But this frequency decreases with age. So if you look into young children with sporadic Burkitt lymphomas, they have reached up to 90% of cases having ID3 and TCR3 mutations, whereas in Burkitt lymphomas in higher age, the frequency is much lower and probably reaches about 30%. In turn, the EBER positivity, so the expression of Epstein-Barr related RNAs, is increasing with age, so EBV positivity inversely increases with age to the mutations. And essentially, that's the same what we see in EBV positive Burkitt lymphomas or endemic Burkitt lymphomas. There are mainly 3 huge studies who have investigated endemic Burkitt lymphomas and or EBV positive Burkitt lymphomas. That's not always clearly distinguished. And if you look into those genes which are differentially mutated between EBV negative and EBV positive Burkitt lymphomas, then all studies come up with ID3, and they show that in EBV negative Burkitt lymphomas, sporadic Burkitt lymphomas, ID3, but also some others, are more frequently mutated than in EBV positive cases. And we have some few mutations like like CHD8, which are particularly effective in EBV positive cases. And these, for example, could be a predisposition gene in endemic Burkitt lymphomas, as we have shown from familiar cases. So why can EBV positive Burkitt lymphomas lack these ID3 mutations if they are really important, or the other mutations? The reason might be that EBV induces a strong DNA methylation as alternative means of gene deregulation. So on the left side are EBV positive Burkitt lymphomas, on the right side EBV negative. Each line is a CPG or part of a gene, and yellow means high methylation and blue means low methylation. And just looking into this print, you can see that EBV positive Burkitt lymphomas have a much higher methylation than EBV negative. And these were selected particularly for those genes which are less frequently mutated in Burkitt lymphomas, being EBV positive than those being EBV negative. So to summarize this, EBV could be one additional player and in inactivating genes beside mutations. And this might explain the differences between the mutational landscape of EBV positive and EBV negative Burkitt lymphomas. Finally, can we prove this model further? So what we did is actually we used a computer-based modeling of Burkitt lymphoma genesis. And if we end up with MYC translocations and 4 of these additional drivers, we can nicely model the biology of Burkitt lymphomas also in a computer. So what we think is that it needs only a very restricted set of mutations beside MYC translocation, which drive Burkitt lymphomas, and that in endemic Burkitt lymphomas, EBV can substitute for a number of these mutations. So that's essentially a model to be proven, but it would explain both the epidemiology of Burkitt lymphomas, the clinical presentation with particularly affection of jaws and ileocecal regions, for example, and extranodal site. It would explain the differences between EBV positive and EBV negative cases. It would explain probably also a predominance of Burkitt lymphoma in the malaria belt. And at the end of the day, if it is proven, it could also be a basis for future development of targeted therapies and probably also early detection. At the end, I would like to thank a big team and a huge team which has supported all this work and have worked with me together in the last years to develop such models. And I thank you for your attention.
Thank you, Dr. Reina. I think that was an excellent session. I've learned a lot myself from it. We will be taking questions after the second speaker, so please stay with us. So our second speaker for this session is Dr. Stephen Kimani. Welcome, Dr. Stephen. He'll be talking to us about adult lymphoma, DLBCL, cost and feasibility of introducing rituximab to treatment of non-Hodgkin's lymphoma in Africa. Welcome, Dr. Kimani.
Thank you, Sitna. Greetings to all of you wherever you are in the world and you're watching this talk. My name is Stephen Kimani. I'm a medical oncologist and assistant professor at the University of Utah. I'm also an investigator at UNC Project Malawi. I am honored to be invited to discuss treatment of adult diffuse large B-cell lymphoma in Africa. So I do not have any disclosures that are relevant to this presentation today. Here are the objectives of this talk. Using data from the first prospective clinical trial for treatment of DLBCL with rituximab in sub-Saharan Africa, this presentation will demonstrate that curative upfront treatment of lymphoma is feasible. It's also safe, efficacious, and likely cost-effective in this region. I hope to make the case that investments in high-quality cancer care may be very prudent when short-term costs result in improved life expectancy thereafter. Non-Hodgkin lymphoma remains a substantial global health challenge, and people living with HIV carry an even higher risk compared to the general population. This is especially notable for such high-grade types such as Burkitt lymphoma and primary CNS lymphoma. Several HIV-related factors affect the magnitude of this increased risk, and this magnitude also differs between non-Hodgkin subtypes. For example, profound immunosuppression or lower CD4 count, as well as prolonged duration of viremia, greatly increase the risk of diffuse large B-cell lymphoma. We see a slightly different pattern in Burkitt lymphoma, which is most common in patients who are less immunodeficient. DLBCL is the most common non-Hodgkin lymphoma, and for the rest of this talk, I will focus on this highly curable malignancy. Rituximab plus combination chemotherapy, typically CHOP, yields an absolute increase in long-term overall survival of about 10 to 20% in high-income countries. This is compared to the standard, the previously standard CHOP backbone. And you can see in these pictograms here that large observational population studies, both from Canada and the US, have captured this dramatic improvement in outcomes, in survival outcomes following introduction and approval of rituximab. Though a similar benefit has been demonstrated among people living with HIV, those with CD4 count less than 50 may experience higher rates of infectious complications based on the AMC clinical trial. So what's rituximab? It's a monoclonal antibody, as we all know, that has specific binding specificity to CD20. It was the first therapeutic antibody approved for oncology patients in the world. The patents on this drug, the proprietary drug Rituxan, expired in 2013 in Europe and in 2016 in the US. Since then, multiple biosimilars have been developed and approved in various countries. Despite being included as an essential medicine by the WHO, widespread adoption of rituximab in sub-Saharan Africa, as well as some other low and middle income countries, has faced many challenges. R-CHOP as first-line therapy for DLBCL received a Category 1 recommendation in the 2019 harmonized guidelines by the NCCN. At the time of that recommendation, there was no published prospective clinical trial of safety, efficacy, or cost effectiveness of this intervention for DLBCL focused on sub-Saharan African population. So we sought to answer these questions by conducting a non-randomized single-arm phase 1/2 prospective clinical trial at Kamuzu Central Hospital in Malawi. You can see the study schema is shown here. We use Reditux, which is the world's first biosimilar, launched in 2007, even before rituximab patent had expired. And this is manufactured by Dr. Reddy's laboratories in India. It's been approved in multiple countries. Patients were enrolled who, after presenting to the cancer clinic and cancer hospital at Kamuzu Central Hospital, which is a large tertiary care facility in central Malawi. It's based in the capital city, Lilongwe. These were all newly diagnosed biopsy-proven DLBCL, and our group has previously described extensively pathology diagnosis, including use of IHC probes. The primary endpoint for this study was safety, which was measured as a proportion of patients who experience grade 3 or higher non-hematologic toxicities, as well as the proportion of patients who experience treatment-related mortality over a course of 6 cycles. Secondary endpoints were multiple. I just want to highlight one for efficacy, which was progression-free survival, overall survival at 12 and 24 months after treatment. We also completed a cost-effectiveness analysis following administration of 6 cycles. In this trial, you can see from this table that we enrolled participants with DLBCL who would be considered to have adverse disease characteristics that typically confer poor outcomes. For example, 73% of patients were HIV positive, 54% had advanced stage disease, and typically stage 3 or stage 4. 41% had bulky palpable disease greater than 10 centimeter, and 68% had an intermediate to high risk IPI score. All patients had elevated LDH with the median elevation of at least 2 times the upper limit of normal. Looking at a comparison between HIV positive and HIV negative participants, their baseline characteristics were not significantly different. For a primary endpoint of safety, 32% of participants developed grade 3 or higher non-hematologic toxicity. The most common was infection, which occurred in 9 patients, which is about a quarter of the population. There was significant difference in tolerable treatment intensity by HIV status. This is reflected by the lower number of treatment cycles completed, higher frequency of treatment delays, as well as a higher frequency of dose reduction. This is probably due to the greater severity and longer duration of neutropenia. It's worth noting that in this study, GCSF was not available. Looking at additional results from this study, we show that there are high rates of complete response, progression-free, and overall survival. It is worth noting that 3 patients with partial responses remain in remission beyond 2 years at the time of this publication. And this likely represents a functional complete response approaching 70%. Typically, we'll be able to do a PET scan to look at residual avidity, but that's not feasible in this setting. No patients were lost to follow-up, which is a notable achievement for a clinical trial in sub-Saharan Africa and anywhere in the world. Irrespective of differences in treatment intensity, there was no significant differences in progression-free survival and overall survival according to HIV status. Our 24-month overall survival of 55% for DLBCL is a significant improvement over our historical unselected controls, which had a 2-year overall survival of around 40%. Majority of deaths occurred due to disease progression. It's notable, however, that 2 deaths occurred due to uncontrolled diabetes in patients who had a complete response to R-CHOP without an alternative infectious or other cause of disease of death identified. These outcomes highlight the infrastructural weaknesses and challenges in the healthcare system that need to be addressed so that patients with non-HIV comorbidities can receive appropriate care for their conditions while undergoing curative treatment for cancer. So this section on cost effectiveness is going to be a slight fast-paced review. I direct you to abstract 125 by Matt Penchar et al. For full details. But I want to highlight the following. For this analysis, we use published data on microcosting from Malawi and the aforementioned clinical trial data. We used a decision tree model to calculate cost per DALI, averted from the health system perspective for the treatment of DLBCL. Compared with best supportive care, CHOP was extremely cost effective with an incremental cost effectiveness ratio of $189 per DALI averted. Compared with CHOP, R-CHOP was possibly cost effective, as you can see from the table pointed there. Again, I refer you to that abstract for more details. In conclusion, in Malawi, R-CHOP was feasible under routine programmatic conditions. Curative treatment of DLBCL among adults in Malawi is cost effective by the current WHO recommendation. It's convincingly so for using CHOP and possibly for R-CHOP. It might be a prudent investment relative to other acceptable health interventions in similar settings. It's also notable that opportunities to participate in clinical trials are scarce throughout the region, which is an issue of cancer health equity. And I think this meeting has focused a lot and has various high-yield talks on this topic. We need to integrate clinical trials in routine cancer care in order to generate high-quality data to inform region-specific evidence-based care. Some of these might be larger randomized multi-center trial, risk adapted and response-guided strategies, as well as long-term follow-up data. I'd like to acknowledge our patients and team in Malawi, as well as in Chapel Hill, North Carolina, and various support and funding mechanisms that allowed these studies to happen. Thank you.
Thank you, Dr. Kimani. I'd like to welcome our co-facilitator, Dr. Sam, who joined us a little later, just to say hello. Dr. Sam?
Hello, it's a pleasure to join you. The session is going very well. I wanted to suggest that we continue with Dr. Shu's talk because Dr. Ryan is going to be available, but I think we're making good time. If that's okay, I'll then invite Dr. Shu to briefly introduce yourself and then give your talk.
Yeah, thank you very much. I'm just getting my slides ready. Very warm welcome to everybody. I hope you can see my slides. And thank you very much for inviting me to this session on lymphoma in Sub-Saharan Africa. So I'm going to talk to you about our program on aggressive infection-related East African lymphomas, or AR-REAL, because it's a little bit of a mouthful, the name. I think everybody on this call is very familiar that EBV-driven lymphomas are highly curable, especially in high-income settings, but they're often diagnosed very late in LMIC. And we have already seen from the previous speaker that this goes not just for EBV-driven lymphomas, but for lymphomas and in generally cancer as well. The data from high-income countries already shown very significant improvements of the addition of rituximab to the chemotherapy backbone in Burkitt's lymphoma. But importantly, the diagnosis is hampered not just because of lack of awareness in the population of the severity of these types of lymphomas, but also because of a further delay in diagnosis once patients are presenting to the healthcare systems. And that's because of a variety of reasons, not least due to the fact that there's a shortage of surgeons who can take biopsies or other skilled personnel who can take biopsies, and tissue processing in terms of high quality pathology preparations, and also the presence of pathologists with an interest in lymphomas. So the goal and broad aim of the AR-REAL program is to develop, validate, and clinically evaluate and deliver effective diagnostic tools for the diagnosis of EBV-driven lymphomas. And the program includes sites in Tanzania, KCMC in northern Tanzania, MNH in Dar es Salaam, and then most recently Bugando and also Lacho in Uganda. And what we're trying to achieve is to compare the best locally available pathology with a new way of diagnosing lymphomas and other cancers indeed, which is a liquid biopsy using analysis of cell-free circulating tumor DNA and subsequent sequencing. The primary endpoint of the final clinical trial will be the time from first presentation to the oncology ward to the diagnostic report. So we're really trying to evaluate whether using a blood test is faster and at least equally diagnostic as using the best locally available pathology. The secondary endpoints include health economics and overall survival of the children. And I should mention here that the diagnosis and treatment, including rituximab for 4 years for all the children on the study, are free of charge and taken up by the study. We have a number of different working groups that reflect the objectives of the program. And for the purpose of this talk, I'm just going to focus on the initial development and technical validation of our liquid biopsy technology. I should emphasize that all the work is done locally to strengthen capacity building, so no samples are leaving the countries. So the background behind the development and the design of the liquid biopsy panel, it's obviously targeting cell-free circulating lymphoma DNA and also the EBV DNA. And we are looking specifically at different modalities, primarily at the overall ctDNA quantity as measured by analyzer. We're then obviously looking for the c-MYC translocations and also for some recurrent mutations that are known to be present in either Hodgkin's disease or diffuse large B-cell lymphoma. With respect to the EBV DNA, we will look for presence or absence of EBV and specific strains, and then quantify EBV in a semi-quantitative way using the read frequency of the EBV DNA, and then look at the EBV specific fragment size difference compared to human DNA. The other attributes of the test, of course, is that it has to be cheap, that the libraries have to be easy to prepare, and that it can be run on a relatively low throughput Illumina sequencer. You can see that we have involved the scientists from the 3 different study sites, and they have started to perform sequencing at Muhas and Dar es Salaam. The panel design is actually 2 panels, panel A, panel B. The panel A, I've just explained to you. Panel B is the panel that will look at sequencing the entire EBV genome in all the positive cases. We have established a bioinformatics pipeline that is run in an Amazon cloud that is HIPAA compliant, and so essentially that allows the team in East Africa and also the team in my site in Oxford to perform all the analyses jointly and together. So we'll be looking at analyzing the EBV strains, both with regards to the whole genome sequencing and then the quantification, SNV detection, translocations, et cetera, et cetera. So that pipeline is now up and running. We have recruited 270 patients, so that were assessed for eligibility, and we have enrolled 162 so far. And you can see how they split into lymphomas and non-lymphomas, because for the technical validation, we're very keen also, of course, to have non-lymphomas included to be able as controls. Plasma samples are collected in specific tubes. In this case, we're using the plastic Roche tubes on all patients and followed by a double spin protocol within 72 hours. I just want to share a little bit of data with you. Obviously, the study has only just started, so we are still in the process of getting all the data together now. But you can see just one of the attributes, as I said at the beginning, is to just simply measure the amount of cell-free DNA. And this is the first data on the first 27 patients diagnosed with Burkitt's lymphoma. So you can see compared to healthy controls that there's clearly a lot of circulating cell-free DNA. We have also tested other conditions in the table, comparing to glandular fever or something that's got nothing to do with EBV, sinus histiocytosis. You can see that the levels are clearly different. Next, we went on to analyzing Burkitt's lymphoma cell lines as a step towards further validation of our panel design. And of course, we know that whether that they have translocations, and we also in one case also know some somatic variants. we know the EBV status on these cell lines. And in the panel, you can see, in the table, you can see that we have been detecting consistently what we are supposed to be detecting using our panel. We've then started to sequence samples in Dar es Salaam, and we have been correlating the results of the translocation detection with the overall ctDNA yield. And as you can see, is that with the exception of the very first sample, with the other samples where we cannot detect the MYC translocation at the moment, it's really down to the input material. And so we are currently further optimizing the translocation calling from these cell-free DNA samples. But we, as you see, we can see already in the majority of the samples with adequate human genome equivalents per milliliter that we can call the translocation well. We've also got some preliminary data on SNV mutation data, and I'm just illustrating this here very briefly. This is, still the analysis, of course, is still ongoing, but we can call mutations using our panel, and we've also started to perform some analysis, at least on the in silico predicted impact, functional impact of variants in certain mutations that we've identified. And we are planning to perform a survival analysis once we have got the data available on all the 162 patients. We have been able to set up a pipeline to look at EBV quantification. Now this is, you can see here compared to performing qPCR from whole blood, we are obviously using plasma and next generation sequencing. So the quantification will be semi-quantitative based on the number of copies and EBV reads per cell. And finally, we've looked at the fragment size profile of EBV-specific circulating tumor DNA. And we essentially are able to reproduce the data that was previously published on nasopharyngeal carcinoma that showed that the EBV-specific fragment sizes are smaller and shorter than those seen in of normal human DNA, but at the same time they are longer than the EBV fragments that are seen in infectious mononucleosis. So that will obviously further help us to differentiate between different stages of a disease and also different stages in different diseases in general. So the next step of this is that we will sequence the remaining 162 patient samples before we are going into the head-to-head comparison against the best locally available pathology. We will certainly develop a diagnostic score from the various variables that we have identified from the panel testing using deep learning. And then apply this score to see whether this technology might increase the speed from presenting to hospital to final diagnosis. So we are also planning to look at the EBV whole genome analysis. As I said, we have a panel up and running. We are also looking at Oxford Nanopore technology that will help us with methylation detection. And we have a clinical descriptive study that looks at rituximab response and in particular toxicity in the sub-Saharan setting. Finally, with respect to sustainability, we are not just doing this for Burkitt's lymphoma, but the plan is really to spin out a social enterprise that would deliver DNA-based sequencing services for research and diagnostics, but with a primarily focus on early cancer detection. And this is really illustrating, I think, how the capacity building for a disease that is very specific to sub-Saharan Africa actually can also bridge the gap to a much broader issue, which is the global cancer pandemic, because once we have capacity to perform cell-free sequencing in sub-Saharan Africa, then that can obviously be used in other applications as well. So a great big thank you to the people in Oxford, and then obviously to all our wonderful collaborators in both Lacho Hospital in Uganda, in Dar es Salaam at MNH and MUHAS, and at the Moshi KCMC. And a great big thank you also for Sam, who is one of the organizers of this session today, for giving us a wonderful advice over the last couple of years. Thank you very much.
Thank you very much, Dr. Anna. I think that was an excellent presentation. I thank all the presenters. I think they've given us a lot of food for thoughts with regards to the genetics and epidemiology of Burkitt's lymphoma, innovations in diagnostics, and bringing treatments that are now, out of patent to Africa, and showing that they are safe for treatment for our African patients. So I'll open the floor to questions. Dr. Sam, do you want to lead the Q&A, please?
Excellent. I'm not seeing the Q&A from the audience, but why don't I begin by firing a question to Dr. Reiner. Your talk was really very interesting. I like the unifying hypothesis that you've advanced. I was intrigued by your statement that microbes might be involved in triggering the onset of Burkitt's lymphoma. In Africa, obviously, EBV falciparum identified microbes, but could you speculate a little bit on the sort of microbes that would be found in the non-endemic setting and how one could identify them?
So, first of all, thanks for this very, very interesting question. So what we see is that the IgA levels develop after birth until, let's say, adolescence. And we see also that the number of, for example, Peyer's patches in the ileocecal region after birth increase to a certain age in adolescence. So this parallels, if you want, at least the steepness of the increase parallels the frequency of Burkitt lymphomas in a certain way. So the slope essentially parallels it. So my hypothesis is that it does not need necessarily to be a pathogenic pathogen or microbiome. It's simply the way that our gut is invaded by microbiome after birth. And this takes some while to get an immunity also to pathogenic and non-pathogenic microbiome. So I would speculate that we essentially talk about gut microbiota or oral microbiota, but that needs not necessarily to be pathogenic. So there are first, you asked the other question, is there a way to identify them? So there are studies ongoing to use the B-cell receptor specificity to identify the antigens which might bind to these B-cell receptors. Again, that might be a difficult task because a lot of the general microbiomes do not have specific antigens, but it's still the surface which widely binds to IgA. So it does not need to be a specific microbiome. So that at the end of the day would be the philosophy that we talk about a physiologic way how a certain, our gut is invaded by microbiome. And to make a final point on this, there are also differences between the microbiome of males and females that is driven by hormones, even the gut microbiome. So the difference in the incidence could also be driven not only by sex chromosomes or sex of the host, but also by the microbiomes which are directed by the hormones. So that's another speculation to be proven.
Thank you very much. I've always wondered how Burkitt's lymphoma is really an entryway into very complex discussions. Professor Shu, you have a question for Dr. Kimani? You are muted right now.
Sorry, Dr. Stephen, a very interesting talk. I really enjoyed this, and it must be a tremendous amount of work. I was just wondering about how much you think that the improvement that you saw in PFS with the addition of rituximab compared to your historical controls, it was about maybe 10, 15%. How much of that do you think is also because of actually improving the supportive care and probably training of your staff whilst you're running the study? Were the 43%, was this also done as part of a study, or was it done just as a historical real world sort of control?
Great, thank you for that excellent question. What I presented was overall survival, but I'll talk about both overall survival and PFS. So we saw about 13-point improvement, and this is looking at a historical control. So the challenge, this was a single arm study, so we did not have a randomized comparison arm. But we had, prior to doing this study, there was a prospective observational cohort study that was basically offering standard CHOP at that time. So that's where our historical control comes from. It was treated at the same facility by the same team of clinicians and diagnosticians, and at the same hospital in Kamuzu Central Hospital. So in terms of how much of that benefit was directly apportioned to intervention with rituximab versus just general improvement in supportive care, that's going to be speculative because it was not studied in a randomized setting, but it's likely going to be due to the rituximab, just given that everything else had stayed the same over a similar time period. In terms of the PFS benefit, our historical cohort had shown a PFS, a 2-year PFS of about 34%. And in this rituximab study, the 2-year PFS was around 59%. So again, similar outcomes to other settings where there's about a 10 to 20% absolute benefit after introducing rituximab.
Yeah, makes a lot of sense. Thank you. Excellent.
Yeah, thanks. So Dr. Mwanzi, you have a question for Dr. Raina?
Yeah. Yes, thank you. Dr. Raina, I really enjoyed your discussion about the different mutations that occur and the potential for targeted treatment. I wondered in your work or in any other work whether there has been a look at our targets that many of us medical oncologists use for immunotherapy, such as programmed death, ligand, tumor mutational burden, or microsatellite instability, because we know viruses can lead to many mutations. Is there any work on that area for Burkitt's lymphoma?
So thank you for this question. So first of all, microsatellite instability occurs in very few cases as a side effect. It's not really driving Burkitt lymphomas. It's more a random association, which we in few cases have seen. The second is that the Burkitt lymphomas is probably characterized by the fact that it has very, very few mutations as compared to other lymphomas. And it lacks something like 9p amplicons, leading to PD-L1 or 2 overexpression. So I think that's not a very, will not drive us towards a very new therapy. And we will have to see what the new pathways will guide us. The standard therapy, at least in Germany, where I'm located, has still not dramatically changed over what has been in the last years from what we know from biology in the last years.
Thank you. So Dr. Riley, you have a question for Dr. Xu?
Yes, thank you, Dr. Xu. I was intrigued. I don't know whether I got it correctly, but I was intrigued by, if I got it correctly, the difference in the size of the cell-free DNA between EBV and the nuclear DNA. If this is true, which I assume is true, then would it be, is there also a difference between integrated EBV and episomal DNA?
So yeah, we haven't looked at that yet, but that is one of the things that we will look at when we can do the whole genome sequencing of EBV, because if I understand your question correctly, because of course the whole genome results will give us the sticky ends and basically pinpoint to the integration site. At the moment, we haven't got that data yet. We are just looking at EBV specific fragments. It's in there, it seems to be that the fragment size is shorter for EBV than it is for the human DNA, fragmented DNA.
Thank you.
So I think we should have some questions for you, but Dr. Shu and Dr. Siebert, I wanted you to comment on your different approaches. So for Dr. Shu, all your sequencing is being done in Africa, and that's a standard that you want to maintain. While Dr. Reiner, all your testing is done in Germany. How do you envisage more regional studies being conducted if samples cannot be tested outside the region where they are collected? And do you think we should be thinking of doing more regional studies of vaccine lymphoma to try and put together this unifying hypothesis that you've advanced? And how do we do it with these different testing strategies?
Maybe I can go first. I mean, one of the aims of or the reason why we've established the sequencing pipeline in an AWS, which is an Amazon HIPAA compliant cloud, is so that we ultimately can invite other collaborators, and whether these are South-South collaborations or South-North collaborations, is completely open and depends on what the consortia decide on what they would like to do. But there's very much a spirit in our consortium that we would like to share and work together in a very collaborative way. And the technology makes this possible. Of course, it's completely possible.
Yeah, I mainly agree with what Dr. Shu is saying. So on the one hand, we also have entered trainings to allow on-site sequencing, at least of some targeted points. I have probably also to say, we have always to think about probably two steps. One is a very explorative and wide step using, let's say, very innovative, advanced technology, which not make it to the routine daily diagnostic field, but gives you the hypothesis and the ideas and the markers to be run in the routine diagnostics. That's the same whether you talk about Africa or Europe or America. It's not that every case gets a whole genome and a whole bisulfite sequence or so, but the idea is to develop with sometimes very expensive technologies the markers which then can go to the fields, and that's independent of location. It's the same in all over the world. And I think these diagnostics with then proven markers has to be run on site with people trained. And I think what we're actually doing today, the internet is showing us how we can collaborate. It's not a distance anymore to talk across 100,000 or 10,000s of kilometers, discuss cases, do common boards, and discuss problems. And the same was true for technology. So I would see this really as two-step, which is an explorative step, which is does not need to be done everywhere to give ideas, and then to run it, roll it out everywhere. And that's the same it's not that every German center sequence completely lymphomas. It's the same here.
Yeah, I agree with you, Rainer. I think there is two just additional points to this. I think number one is that in particular, the plasma DNA sequencing, as I said in my talk, is we're not just talking about improving diagnosis of a few kids with Burkitt's lymphoma or making this a bit more speedily. Obviously, we all know as pathologists that biopsies will always play a critical role in the diagnosis. So This is more about enlarging the scope and also ultimately thinking about how we can bring early cancer detection and screening into sub-Saharan Africa. And that's not something that can be done outside of Africa, because you're talking about, millions of samples having to cross the ocean. That's just not going to happen. So obviously I might be talking about something that is 50 years away. I hope not. I hope this is something that Africa will embrace, and the policymakers and payers and the WHO will embrace very soon, because we know that the outcome of early stage cancer is so much better, and that it is so much cheaper to treat a patient with stage 1 or 2 cancer than somebody with stage 3 or 4 cancer. And the first multi-cancer screening test has been approved by the FDA. So the last thing we want is yet again Africa lagging behind by 50 years when there's a global cancer pandemic going on, and it's going on in Africa. So I think that is really where I'm coming from with this specific project. The second point, I think, in terms of capacity building, is that it's not just about building diagnostic capacity, because in order to train the future scientists and the future innovators in diagnostics and in research, we need to build capacity in research today. And so I see this program also as building research capacity, not just diagnostic capacity, although it sounds like diagnosis, and it is to a large extent diagnosis and innovation. You can imagine that once you have a sequencer, you can start doing lots of things outside, completely unrelated to Burkitt's lymphoma. And so the role of the social enterprise will really be to ensure access to sequencing capability, that is local and that is close to the university and that supports, locally led programs in East Africa.
Yeah, but I think we don't have disagreement on this. I think we share the same view.
Yeah.
Okay, we have a question from Dr. Kimani.
My question is, Dr. Shu, so I really enjoyed listening to your talk and seeing how much, high quality advanced testing you're doing with these samples. Can you comment on whether HIV and its resultant effect on immunity affects, circulating tumor DNA?
That's a very interesting question. So I didn't have time to get into this, but we have, obviously we're collecting a lot of data on these children as well, including their HIV status. So hopefully we will be able to give you some results on that, but it is, it's an interesting question.
So I don't know whether our colleagues at IOTIP have identified some questions. I haven't seen any in the chat, but I'm not able to see it well. Dr. Mwanzi, are you able to see the chat questions?
No, but the hosts at IOTIP can confirm if they have any questions in the Q&A.
No, there are no questions on the Q&A session.
Okay, thank you.
So maybe we can continue discussing. I had a question for you, Dr. Kimani. I was really intrigued by your introducing rituximab. Could you comment a little bit about, the cost and how you procured it? Was it procured in Malawi, elsewhere? Were there any difficulties?
Yeah, so this was, we use a biosimilar from India. So this was procured with support from the manufacturer, Dr. Reddy's laboratory. So typically, we had enough supply for the patients who were enrolled in this clinical trial. But as you probably know, outside of a well-established programmatic effort like UNC Project Malawi, which works closely with the Ministry of Health and has decades of goodwill and partnership in the country, that supply chain constraints do creep up oftentimes with medications for cancer treatment. So for this one, it was not attached to any cost to the patient. All treatments were free for the patients, and the study supported purchase of the biosimilar from India at a favorable rate, though we did use the microcosting data that looks at total cost, including across the pathway of treatment and follow-up and other interventions.
Thank you. So we've spent 1 hour, but we're given 5 minutes. So before I decide that we can use up the remaining 15 minutes, I just wanted to confirm with the speakers if they're still available. And if you have to leave now, that would be okay. But if you're available, we can use 15 minutes to discuss amongst ourselves.
Dr. Reina, Dr. Kimani, are you still able to stay for another 15 minutes?
Yes.
So, and for me, unfortunately, I have to get going for early morning clinic. So I'll be stepping off.
All right, thank you very much, Dr. Kimani. I think you had an excellent presentation, and thank you for participating in the Q&A.
Thank you, everyone.
Dr. Reina, Dr. Han, do you have another 15 minutes?
For me, okay.
Yeah, I'm fine as well. I'm thinking about questions.
Yeah, as you're thinking about questions, I have a question for you, Dr. Shu. I mean, you spoke about training and technology transfer, sustainability. You didn't go too much detail about that, but could you say a few more things about how you're approaching this? Because you're introducing a very complex approach to vaccine lymphoma, and I suspect that you're having all sorts of issues that you have to overcome.
Yes.
How are you managing?
Yes, I mean, obviously the pandemic hasn't helped to run a program across 3 countries at least, if not more, when you're thinking about all the collaborators. So that's been a challenge. Having said that, of course, on the one hand, there's a challenge. On the other hand, it's also a blessing, because what we have realized is that an awful lot can be done in terms of remote training. And we have all learned to use technology in a much more effective way, and that also includes the training sessions that we had. Effectively, what we've been focusing on is a lot of technology transfer from the group in Oxford to the group in both Dar es Salaam, and then invited the scientists from Uganda and from KCMC to join some of the face-to-face training sessions in between lockdowns. So that was, I think, on the wet laboratory training side of things, that was reasonably successful. We've also supplemented the face-to-face training with video clips that was specifically really kind of taking shoots of the library preparation and of the sequencing setup. We've had a lot of support from Illumina to help us also with on-site training on various different machines. We've had support from Oxford Nanopore Technology. I need to mention them all now, for providing sequencing and training locally on site by their local representation. I think the main challenge going forward in terms of training is bioinformatics. And that is, I think, a particular issue that I was a little bit surprised to encounter, because I had imagined that with H3 Africa and all the initiatives that are going on now around the African genome, that actually there'd be lots of clever bioinformaticians hanging around in Africa waiting to get their hands on sequencing data, but it is more complicated than that. So I'm glad that we have an AWS cloud. I'm glad that we can share the data, and that, you know, at least in theory, lots of people can work and on the data, and also can be trained on the data. And for me, one of the main sort of one of my main next goals is for this program is really that we are building capacity in bioinformatics. And so there are some initiatives with respect to creating an MSc program in East Africa that is specific to bioinformatics. I think the challenge is really for the students to be able to work on data and to get their hands on data and to analyze data that is meaningful for them, which by definition means it has to be data generated on Africans, and there's just not that much data that is available. So that is I think a real challenge. And I'm not sure, I know, again, I think it probably takes a generation to sort out, but it might, you know, I'm just hoping that it'll be a bit faster than that. I should say that now that lockdown is finished, I'm really hoping to also be able to have visitors coming to Oxford for training. We have already PhD students registered in their local institutions, and we have also now one MSc student registered with an Oxford MSc on the program. We have another student who's gone to probably, you know, thanks to his prior work on Emblem, gone off to do an MSc in Birmingham. So there is capacity building with respect to university degrees. One of our senior hospital collaborators is now a senior NIHR training representative and fellow, with basically joining the National Institute of Health Research training program on training the trainers. So that, you know, there's a lot of training outside of the actual program that we are facilitating, I think, thanks to this program already.
I have a question for Dr. Anna. Are you at any point expecting to expand your work in other EBV-related diseases such as nasopharyngeal carcinoma, which is also quite prevalent in Eastern Africa?
Yeah, so we've had discussions on this about this with the oncologists, and yeah, clearly that, you know, we have to be very careful how much money we spend and on what disease we spend. So, but you're right. It's obviously there's a lot of work a lot of the groundwork has already been done by Dennis Lowe and his team in China. So, what we are doing is effectively using very similar approaches with respect to the EBV analysis. As you could see from my presentation, the PNAS paper that they had, we basically find the same, very similar results. And once we get started with the whole genome sequencing of EBV, it'll be the same again. So it could well be that, this is speculation at the moment, but it could well be that at the end, we would come up with a test that is not very dissimilar from the one that's been proposed for the Chinese screening program. But rather than, you know, not the qPCR, but what Dennis is now proposing to do, you know, on the sequencing platforms, which is, you know, looking at EBV fragment size and sticky ends. Yeah, so I think it would be it'll be very interesting. I've had myself, so Dennis Lowe is a collaborator on the program, but we haven't really roped him in at the moment because we haven't got any data. But once we have some data, it would be very interesting to compare our data on the Burkitt's lymphomas with the Chinese EBV data.
Thank you.
Yeah.
We have a question here from Chris Williams. How does Dr. Siebert's explanation of lymphogenesis explain the inverse relationship between the global incidence of childhood acute lymphoblastic leukemia and endemic Burkitt lymphoma?
So there is data showing that also acute lymphoblastic leukemia could be driven by microbiomes. There's data in experimental mouse models from Julia Hauer and others suggesting that there could be a difference. But at the end of the day, acute lymphoblastic leukemia comes from a very different cell. It's a much more immature B cell, which does not necessarily need that much B cell receptor function as it's done for a more mature Burkitt lymphoma. So whether this is really there is discussion whether the microbiotic or microbiome in ALL could give some environment or also leads to more higher likelihood of some aberrations, but I think the role of B cell receptor signaling in precursor B is not that strong than in mature B cell lymphomas. So I would see this completely different at the moment, though there is also data on epidemiologic data or so that there could be an association with some microbiotic. To be honest, I haven't thought about this inverse relationship. I need to think about this. Probably in 2 years from now, I could have an idea. But at the moment, I have really to think about. It's a good question. Thank you.
Reinhard, stupid question. I should probably know, but I don't. Have people looked at the epitopes in Burkitt's lymphoma and to see whether they are representing some form of antigens that might be associated with gut?
Paper submitted.
Very good. Yes, because I think that is sort of the easiest way to get the answer potentially, if it's positive.
I'm not sure about this because so it's what comes out of a paper is not microbiome at the end of the day. But one problem of some of these profiling studies is that you have such antigens which are more ubiquitous, and so you actually experimentally block them, and these might be the antigens we are interested in. So that could be one problem of these studies. But there are definitely, I'm aware of at least 2 or 3 laboratories doing the cloning of B cell receptors, expressing it, and I'm aware of one paper which is under review at the moment.
And this is comparing endemic with non-endemic.
No, not yet. It's starting first of all, but again, we might have one problem. We might have probably to express IgA. And that's not what these studies usually do. Because if we follow this IgA hypothesis, when we talk probably something protective, which is pretty different to what we usually do as immunoglobulin receptors. And at the end of the day, there is some B cell receptor signaling in Burkitt's, but it's not that strong as it could be in other parts.
Thank you all very much. I'd like to thank you for an excellent session and for using your time to have such a rich discussion, which was really excellent. Thank you all very, very much for that. Right, well, this is the last session on our stream today, and it's been a very successful Aortic 2021 conference. And for this, we have to thank our sponsors, our conference organizing team, the technical team, the speakers, and of course, you, the audience. I hope we will see you in 2023 in Senegal for the next Aortic conference. Thank you and goodbye.